Good afternoon, friends. Welcome to the teleconferencing session today. As you might be aware that today we have 4 teleconferencing sessions. The first 2 sessions will be dedicated to interpretation of ECG, and the next 2 sessions will be on endocrinal spotters and interpretation of data. I hope most of you have gone through the website. For the month of December, we have planned 3 more sessions on 16th of December, which happens to be Saturday. We are going to have session right from the beginning from 11 o'clock to 5:15. The sessions will be on 16th will be devoted to radiology. We'll have a presentation how to present a long case in radiology, a short case in radiology, then ultrasound guided procedures, neuroradiology, and the last 2 sessions will be dedicated to nephrology, where we are going to discuss nephrotic syndrome and renal failure. The next session, which is scheduled for 17th of December, which happens to be on Sunday, again we are going to begin our transmission from 11 o'clock and it will continue throughout the day till 5:15 p.m. On 17th, we are devoting the sessions exclusively to the dermatology. So you will be exposed to what are the clinical way of examining a patient who is suffering from conditions, dermatological conditions. Then what are the basic applied sciences like physiology, pathology applied to dermatology. Then how to examine a patient, I have already told you. Then some of the common clinical procedures which you should keep in mind as far as dermatology is concerned. So 17th is exclusively devoted to dermatology. Then on 23rd of December, which again is a Saturday, the morning session will start again at 11 o'clock, and first 2 sessions will be again related to dermatology, and the next session will be related to medicine. On 23rd, we are going to cover clinical procedure and lab procedures in dermatology, and we are also going to cover demonstration of pleural biopsy, then endotracheal intubation and pulmonary tuberculosis. So this is the training, the teleconferencing schedule for the month of December. I am sure that all the DNB candidates in our training institutions are aware of this. Please keep on watching the website, and we may add some more teleconferencing session for the month of December for the benefit of the students. Here I will like to mention, if you want to utilize this opportunity given to you, especially I request the DNB candidates that they must download from the website the topics, and they should do some preliminary reading. Only then you will be able to make the best use of these teleconferencing sessions. And let me tell you that these teleconferencing sessions cannot replace the routine training program, which I think should be regular training program must go on in our accredited hospitals. Because we are able to interact with you through this teleconferencing mode only 3 or 4 times a month. But more important is that at your own institution level, I request the DNB candidate, they should make DNB clubs. Say if you are 4 or 5 DNB candidates in a particular specialty, you must make DNB clubs and start making presentation to each other. You can divide the topics, you can even decide about the cases which you should present to each other. That will give you a lot of confidence and improve your communication skills. And at the same time, I request all our DNB coordinators and consultants that you fix some time for the DNB candidates a week, maybe 1 or 2 hours a week, where you can have discussions on the case presentation. You must have regular seminars, programs going on. I request that the syllabus or curriculum is on the website. And if you don't have the curriculum, like for 10 major specialty, we have the revised competency-based curriculum on the website. For rest of the specialty, the copy of the curriculum is with the DNB coordinator or with the library in the different institutions. So all the DNB candidates should be aware what is expected from them during 3 years of training. Because if you are not clear what is expected from you, naturally your efforts will go waste. And it is better that right now, if you are in first year, second year, have a copy of the curriculum, either download from the website or you can have it from the DNB coordinator, and start making efforts right now. As you know, the DNB program and DNB examination is slightly different from the MD-MS examinations. Especially in DNB, you have to first clear the theory examination, and only then you are allowed to sit for the practical examination. Unlike in MD and MS examination, where even if you are the theory papers are sometimes not even graded. So it is very important for you that you should start planning for your theory examination. And for that, it is very important that you must have a copy of the syllabus, and you should also have a plan how you can prepare for your theory examination. I hope you have downloaded the sample questions from the website. For 10 major specialty, we have put sample questions on the website, and also in the competency-based curriculum which is on the website, there are sample questions there. So if you download all these questions, which may be about 100 or odd questions for each specialty, and you can start preparing for them, you must sort of discuss with your colleagues what are the key points if this question comes in the examination. This preparation is very, very important. And then you can have consultation with your consultant. They can help you how you can improve upon your handwriting, how you can improve upon the way you make a presentation in the examination. Because as per the current requirement, you must secure 50% marks in theory examination before you sit for the practical examination. Then those of you who are preparing for the practical examination, again I will request, please download from the website what are the important cases which are likely to be there as a long case or short case. You can have further discussion with your colleagues or with your consultant, and you must prepare a list of common short cases, long cases, common things which are likely to be asked during the ward round, what are the common spots which can come for viva, some x-rays, some CT scans, so and so forth, and start making efforts in that direction. So if you look into the website, now we have put certain key points for case presentation, like some common cases in 10 major specialty in history. What are the important key points you must never forget? What are the salient clinical findings which you should look when you are examining that particular case? Then what are the important differential diagnoses? What are the key investigation and management aspects? So already for important cases we have put these on the website. You can download from the website, have discussion among yourself, have discussion with the consultant, and further modify those key points. The most important thing to remember is there is no substitute for practice. Presentation is very, very important. Your communication skills are very, very important. So unless you have done this practice beforehand, in examination you are given only 40-45 minutes, and sometimes it is not really possible to do the complete examination if you are not prepared, if you are not practiced that before. So my request to all of you who are preparing for the practical examination is that you must have lot of presentations. Say, if you download those cases and list those cases, it may be around 40-50 cases in each specialty. So if you plan well in these 40-50 cases, the chances are that you will be able to perform better, you will have better confidence. And whenever you are making a presentation of these cases, please present those cases in the same sequence and pattern, so that you are attuned to this pattern, and in the final examination you are able to do well. Another point I would like to mention before we shift to the expert for discussion is your thesis part of it. Sometimes it happens that you clear your theory examination, sometimes even some of the candidates clear practical, but their thesis is rejected. So my request to all the candidates, especially those who are in first year, please download from the website. We have put certain exercises which will help you in planning your proposal and also in your thesis. We have about 18 exercises and the corresponding handouts which you should refer, that will help you in improving your quality of the thesis. And at the institutional level, I will request all the DNB institutions that they must have a operational committee, thesis progress review committee. And this committee should meet every quarterly at least and give the feedback to our candidates where they can improve. I hope now most of the institutions are doing the 6 monthly appraisal. The purpose of 6 monthly appraisal again is to give you confidence, improve your communication skills, and give you competencies and prepare you for expert as an expert, and give you skills so that in the examination you are very, very comfortable. In the 6 monthly appraisal, we expose you to the theory examination on the same pattern as we have in the final examination. There are 10 short structure questions on the topics which have been covered in the previous 6 months. Then you have a long case, short case, ward round, viva, and so on and so forth. The purpose basically is to give you repeated exposure by an expert from outside. Then in 6 monthly appraisal, we also expect that the appraiser who is coming will give you feedback on your logbook. Because what I feel, logbook again is the area which needs improvement. Most of the DNB candidates think that the logbook is for the benefit of the examiner. No, it is for your own benefit. So whenever you're doing a clinical procedure, please record all the details, like besides the identification data of the patient, what are the salient key points of this case as far as the history is concerned, or clinical examination, clinical findings are concerned, what are the differential diagnoses, what type of different investigations were done, and then what was the progress. And ultimately at the end of it, you must write what are the key points which you have learnt out of this case. So this is no point just writing one line in the logbook of a particular procedure. I feel that you must download the revised format, which again is on the website in the curriculum, and write as much detail as possible. This logbook should serve as a ready reckoner for you whether you are preparing for examination. If you have done those procedures, you can quickly go through that and have better performance in the examination. And subsequently, when you work as a junior consultant after your qualification, this logbook should also you can refer to this logbook whenever it is required. So my request to all of you, please prepare the logbook in a proper way, and the logbook is there to help you, not to satisfy the board or the examiner. Then I hope you know that the board has started certain publication. We have started with our journals. 2 issues of the journals are already out. The first issue was on thyroid, and the second issue, which we have released last month, was related to breast problem, and the third issue again is coming on tumors. So this journal is basically meant for you. So out of your thesis, you can share some of the research findings in this journal. You can contribute in this journal as editorials, add commentaries, as recent advances, as review articles, or maybe as book reviews or correspondence of some interesting cases which you observe. This is very crucial for you, because now I hope you know that DNB qualification is equal to MD, MS in all respect, including your appointment in a teaching institution. So after your DNB, if you have 2-3 publications to your credit, I am sure that you will get better opportunities for being selected in a teaching institution as a teacher. So this is opportunity for you. This is your own journal. The journal is available full text, free of cost on the website also. So first issue was on thyroid, and it covered anatomy, physiology, clinical investigation, management, and reduce everything. So if you have gone through this issue on thyroid, I hope as far the DNB requirement is concerned, the material is enough. The second issue was on breast problem. So again, the sequence was the same. So my request to all the DNB candidates and the consultant, please contribute for this journal. This is your journal. Second publication which we are doing every quarterly is our bulletin. This is a quality quarterly bulletin which we publish. Here the one page is dedicated to the National Board of Examination accredited hospital. So you can send me photographs, you can send me a little profile about your hospital, what unique things, new things you are doing, so that all institution can share that. Then one page is dedicated to the DNB students. As a student, what are your experiences you can contribute, and one page is dedicated to the DNB teachers. So these are some of the publications which I thought I will use this opportunity to inform all of you. You can share your experiences. Now I will not waste more time, and I will like to introduce the experts who are here with us for the first 2 sessions. As I said, this session is dedicated to interpretation of ECG, and I have requested my experts to limit themselves to the level of DNB candidates in general medicine, and maybe some of the tips for the DNB candidates who are doing cardiology, DNB in super specialties like cardiology. So to my left, I have Dr. Karthike Bhargava. He is a consultant in a Scott Heart Institute and Research Center, and incidentally he is also DNB cardiology. To my right, I have Dr. Vanita Arora. She again is a consultant and interventional cardiologist and electrophysiologist at a Scott Heart Institute and Research Center, and she is also DNB cardiology. So I think this is a unique opportunity that both our experts are DNB, and they have a lot of experience. They are working in a very premier institution in Delhi. And I hope all the students who are watching this teleconferencing program, they will make the best use of this opportunity provided to you. I will start with Dr. Bhargava, and I will request him to tell our students about the basics concept of ECG. Maybe we can start with what are the things which you should keep in mind when you are recording ECG on a patient, and then what is the normal ECG pattern. So basic preliminary things about ECG as a tool for investigation. Dr. Bhargava, please take over.
Thank you, Dr. Sood. Good afternoon, friends. And in our next half an hour or so, we will be covering about electrocardiography, from basics to clinical practice. And when I will be going through my slides, some of you may feel that you are aware of most of the things in these slides. But let me stress it at the outset that basics are very important because they form the foundation of a building. And so whosoever is interested in cardiology, or even not in cardiology, even in general practice, you are likely to get confronted with ECGs of your patients. So everybody, I think everybody who is practicing medicine should be aware of the ECGs, and basics form the foundation when you can interpret an ECG and give the best to your patient. So today we will be covering electrocardiography from basics to clinical practice. The first slide, what's the definition? Let's define few terms first. Electrocardiography is a technique of recording the sum total of electrical activity of the heart on the surface of the body. Whereas electrocardiogram is the graph obtained by the above technique and which is commonly known as the ECG, and the machine which records this ECG is known as the electrocardiograph. It basically consists of a sophisticated galvanometer that detects and records changes in electromagnetic potential between a positive and a negative pole. It's basically a galvanometer. So whosoever is interested in physics will find it very easy to understand how it records the changes in electromagnetic potential and then gives us such a valuable information about the electrical activity occurring in the heart. Now in the next 20-25 minutes we will be seeing various concepts about ECG, the ECG leads and the recording technique, basic deflections and intervals, the description of an ECG, and then we will see after the normal ECG some certain abnormalities like chamber enlargement, fascicular blocks, myocardial ischemia and infarction, and a few miscellaneous conditions which are encountered in common practice. Now let's see what does an electrocardiographic paper looks like. Electrocardiographic paper is a special kind of paper. It's like a graph which you must have seen during your mathematics schooling. It's a graph with each millimeter on the horizontal axis represents 0.04 seconds or 40 milliseconds when the ECG is recorded at a paper speed of 25 millimeter per second. That is the conventional speed at which an ECG is recorded, and at that speed 1 millimeter in the horizontal axis represents time and 1 millimeter represents 40 milliseconds or 0.04 seconds. So whenever you see an ECG, it is always a good idea to see at what speed the ECG has been recorded. Conventionally it is recorded at 25 millimeter per second, but at times the physician or the cardiologist may have ordered a special ECG when the speed may have been 50 millimeter or say 100 millimeter per second. So at the bottom of the ECG it's always written the paper speed, which is conventionally 25 millimeter per second. And the vertical measurement on the graph shows the voltage, and 1 millimeter is equal to 0.1 millivolt of the amplitude. So the horizontal axis represents the time scale, whereas the vertical measurement is the amplitude of the electrical potential. Now when we record an ECG, what are the electrodes to be placed and how are they placed? Now we have conventionally a 12 lead ECG, and in which we place the electrodes, one in the right arm, other in the left arm, one in the left leg, which are all the active electrodes. Another electrode is put on the right leg, and that is for proper earthing and does not take part in active recording of potentials. And then apart from this there are 6 electrodes which are placed on the chest, and they are known as the precordial electrodes. They are from V1 to V6. V1 is placed in the right 4th intercostal space in the parasternal region. V2 is placed in the left 4th intercostal space in the parasternal region. V4 is placed at the apex of the normal heart, that is in the left 5th intercostal space in the mid-clavicular line, and V3 is placed at a point midway between V2 and V4, and V5 is placed at a point which is on the left anterior axillary line at the same horizontal level as V4, and V6 is again placed at a point in the left mid axillary line at the same horizontal level as V4. So these are the 6 precordial positions of the leads, and conventionally the ECG records 12 leads, which are the frontal plane leads and the horizontal plane leads. The frontal plane leads records the bipolar limb leads, which are lead 1, lead 2 and lead 3, and modified unipolar limb leads, which are the augmented right, which is known as AVR, AVL and AVF. R stands for the right arm, L stands for left arm, and F stands for foot. And apart from the frontal plane leads, we have the horizontal plane leads, which are the unipolar leads and known as the unipolar precordial leads from V1 to V6. So these are the conventional lead positions, and at times the physician may order other special leads, may ask for more precordial leads, say V7 to V8, V9, or certain other special leads which maybe we'll discuss sometime later. So when we place the electrodes, how does the ECG record the potential? Limb leads are bipolar leads. Bipolar means it detects the difference in electrical potential between two poles. One is a negative pole and the other is a positive pole. So limb lead 1 records the electrical potential between the left arm and the right arm, in which the right arm is the negative pole and the left arm is the positive pole. Lead 2 detects the electrical potential between the right arm and the left foot, where the right arm is the negative pole and the left foot is the positive pole. Similarly, the lead 3 depicts the electrical difference in electrical potential between the left arm and the left foot, where the left arm is the negative pole and the left foot is the positive pole. So these are known as bipolar leads, and apart from these we have the precordial leads, which are the unipolar leads. The unipolar leads depict the difference in electrical potential between the active electrode, which is placed on the chest, and an reference electrode, which is a combination of the three leads which are connected to each other. So they form a common reference electrode which is taken as 0, and the difference between this and the active electrode placed on the chest gives the unipolar precordial lead potential. So these are the way in which we record the different leads. Now how is the ECG deflection produced? Now if the current flows towards the positive pole of the ECG lead, a positive deflection is recorded on the graph paper, and if the axis of the vector of the electrical current is away from the positive pole of the ECG lead, then a negative description occurs on the ECG graph. So this is the basic principle how a positive and negative deflections are produced on the ECG. And if the vector is parallel to the ECG lead, then the maximum amount of amplitude of the potential is inscribed. Whereas if the vector of the current in the lead is at an angle, then the amplitude is somewhat decreased. And if the vector of the current is perpendicular to the direction of the ECG lead, no amplitude will be produced, no deflection will be produced at all. So this is the basic principle how an ECG records the basic deflections, a positive, negative, or no deflection at all. So now an ECG has certain basic deflections and intervals. The basic deflections include the P wave, the QRS complex, the T wave and the U waves, and the intervals are the PR interval and the ST segment. The P wave basically depicts atrial depolarization. The QRS complex depicts the ventricular depolarization. The T wave depicts the ventricular repolarization, and the genesis of U wave is controversial, but most of us think that it depicts the repolarization of the Purkinje fibers of the ventricles. So these are the basic deflections produced on a normal ECG. And how are they produced? As all of you know that the normal pacemaker of the heart is situated in the sinoatrial node, which lies at the junction of the SVC and the right atrium. It causes depolarization of the atria, and this depolarization produces the P wave. Then the impulse reaches the AV node and then goes to the His bundle, which divides the current into the left bundle and the right bundle. The left bundle again divides into the left anterior fascicle and the left posterior fascicle, and this way the current reaches the Purkinje fibers in both the ventricles and depolarizes the ventricle. So the PR interval depicts the interval between the onset of P wave to the onset of QRS complex, that is from the onset of atrial depolarization to the onset of ventricular depolarization. So it depicts the time it takes from here till it reaches the ventricle. So this is the whole lot of time, and it is depicted by the PR interval. This is again a normal electrocardiographic deflections of the different waves, the P wave, the PR segment, the PR interval, QRS complex, the ST segment, and the T wave. So whenever we get an ECG, how to describe an ECG? It is always better to, whenever you see an ECG, to see it systematically so that you don't miss anything and reach a proper diagnosis. ECG is highly valuable in not only in cardiology practice, but even otherwise. If you are a surgeon, you may get a patient who has certain heart disease, and during pre-anesthetic checkup you find that he has some abnormality in the ECG. So ECG is very important in all aspects of medicine, and everybody of you will also be confronted with it sometime or the other. So when we describe an ECG, we have to go systematically. We see what is the rhythm, what is the rate, what is the QRS axis, then we go to the individual waves, the P wave, PR interval, QRS complex, ST segment, T wave, U wave, and the QT interval. Now how do we calculate the heart rate on an ECG? As I told you, 1 millimeter or 1 small square on the ECG represents 40 milliseconds. So going by this, if we divide the RR interval in millimeters and divide this RR interval, divide 1500 by the RR interval, we get heart rate in per minute. So normal heart rate varies from 60 to 100 per minute. So in a patient who has normal heart rate, the RR interval will measure from 3 to 5 large squares. Now the QRS axis. As I told you that limb leads depict the electrical potential difference between a positive and a negative pole. You see that left lead 1 depicts the difference between left arm, which is positive, and the right arm, which is negative. Similarly, lead 2 and lead 3, and AVF, AVR, and AVL, they depict the electrical potential between the limbs and a reference electrode. So if we combine this into a hexaxial system, and horizontally we say it is 0 degree or 180 degree on the left side, then we can divide the ECG QRS axis into 4 quadrants, from 0 to minus 90 degree, 0 to plus 90 degree, 90 degree to 180 degree. And we can place the normal leads in this hexaxial method. Lead 1 will be oriented this way, lead 2 will be oriented this way, and lead 3 will be oriented this way with a positive and a negative pole. Similarly, AVL, AVR, and AVF. So we have to calculate the QRS axis in the frontal plane using this hexaxial vector method. Normal QRS axis varies from minus 30 to plus 90 degrees, whereas if the axis of the QRS is plus 90 to plus 180, we call it as right axis deviation, and if it is minus 30 to minus 90 degree, we call it as left axis deviation, and between minus 90 to 180 degrees, we call it as a northwest axis. So if we see the ECG in lead 1 and lead AVF, we can easily determine what is the axis. If the QRS is predominantly positive in lead 1 and negative in lead AVF, then the axis will be somewhere here, and we call it as a left axis deviation. If the QRS complex is predominantly positive in lead 1 and positive in lead AVF, the axis will be somewhere here, and we can easily say that the axis is normal. If the lead 1 shows predominantly negative QRS, because negative is in this direction, it will be going away from this. So if the lead 1 shows predominantly negative QRS complex and AVF shows positive, that means the axis will be lying in this quadrant, and it will be known as the right axis deviation. Suppose the lead 1 and AVF both have negative QRS complexes, then the axis will lie in this quadrant, and it will be a northwest axis or indeterminate axis. So this is the way one can calculate the QRS axis. Now this is an ECG. One has to calculate the axis. So one has to see lead 1 and lead AVF. You see that the lead 1 is positive and lead AVF is negative. So what will be the axis? Left axis. Very good. So this is a slide of left axis deviation on the QRS axis. So what are the causes of left axis deviation? It can exist as a normal variant in some persons. It can be because of mechanical shift in the mediastinal cavity. It may be a feature of left anterior hemiblock. It may occur with left bundle branch block. It may be seen in patient with WW syndrome, in patient who have congenital heart disease with atrioventricular septal defect, or it may be due to a ventricular ectopic rhythm. So these are not the comprehensive list of causes of left axis deviation, but if you find a patient with left axis deviation, one has to look for all these causes. Now this is another ECG in which you see that the lead 1 is predominantly negative and lead AVF is positive. So what is the QRS axis in this patient? Right axis. Very good. So this is a ECG of right axis deviation, and when we see the causes of right axis deviation, again a normal variant can have a right axis deviation. Right ventricular hypertrophy as a feature of right bundle branch block in association with left posterior hemiblock in patient with dextrocardia in which the heart lies to the right side, in some types of WPW syndrome, again in patients with ectopic ventricular rhythm, or again due to mechanical shifts in the heart. So these are the possible causes of right axis deviation. Now we coming to one and the ECG deflections one by one. The P wave, the normal P wave, the duration of the normal P wave is less than 120 milliseconds, that is less than 3 millimeters on the ECG, and the height is less than 2.5 millimeters or 0.25 millivolts. And the P wave is upright in lead 1, lead 2, V4 and V6 and in lead AVF, and is inverted in AVR, whereas it may be variable in lead 3 AVL and in the other chest leads. Inverted P wave in lead 2, 3 and AVF may mean an ectopic atrial rhythm or junctional rhythm. This is because of abnormal depolarization of the atria from below upwards, leading to a ectopic inverted P waves in leads 2, 3 AVF. P wave of increased amplitude indicates atrial hypertrophy or dilatation, and seen in atrioventricular valve disease patients, patients with hypertension, patients who have cor pulmonale, or patients with congenital heart disease. Increased width of the P wave more than 3 millimeters indicates left atrial enlargement or diseased atrial muscle. You see that the P wave here is not only wide but it is bifid, like an M shaped. So this indicates left atrial enlargement. Biphasicity indicates left atrial enlargement again, especially when the second half is negative and prominent in lead 3 and lead V1. Notching, as seen in the previous slide, also indicates left atrial enlargement, and it is known as P mitral when the duration between the two peaks is more than 40 milliseconds. Peaking indicates right atrial enlargement, as is seen in chronic lung disease, and is known as P pulmonale. Now PR interval is the interval measured from the onset of P wave to the onset of QRS complex, and it is the time taken by electrical impulse to move from sinus node to ventricular muscle fibers. Normal interval varies from 120 to 200 milliseconds, that is from 3 to 5 small squares. Prolonged PR interval is a feature of AV block, and it can occur due to coronary artery disease, in patients with acute rheumatic fever, certain drugs like digitalis or beta blockers, or in persons who have high vehicle tone like athletes. In this you see a PR interval of about 250 milliseconds. Short PR interval is uncommon, and it is seen in patients who have AV junctional or low atrial rhythms, in patients with WPW syndrome, in Lown-Ganong-Levine syndrome as a normal variant, and sometimes in patients with pheochromocytoma. Here you see an ECG of a WPW syndrome where the PR interval is very short. Now coming to the QRS complex, when we look at a QRS complex, we have to see all these things: the duration, the amplitude, presence of Q waves, electrical axis, transition zone, general configuration, slurring and notching. Now duration normally is from 50 to 100 milliseconds, that is 1.25 to 2.5 millimeters on the ECG, and higher duration indicates intraventricular conduction defect or a ventricular arrhythmia. Low QRS amplitude is defined if QRS in each of the limb leads is less than 5 millimeters or in chest leads less than 10 millimeters, and it can be seen in variety of conditions like myxedema, diffuse coronary artery disease, pericardial effusion, amyloidosis in patient with thick chest wall due to obesity, or patient with Endosocpy, or patients who have emphysema. High QRS complex amplitude is a feature of ventricular hypertrophy, which may be either due to chronic pressure or volume overload, and it is also seen in infiltrative disorders like glycogen storage disorder or in patients who have thin chest wall. Now Q wave normally is seen in one AVL, AVF and left precordial leads with an amplitude of 1 to 2 millimeters. A pathological Q wave is defined if the duration of the Q wave is more than 40 milliseconds and the depth is more than 25% of the R wave amplitude. Causes of pathological Q waves, as all of you know, most common cause is myocardial infarction, but there are other causes one should also know, include left ventricular hypertrophy, cardiomyopathies, left bundle branch block and WPW syndrome. ST segment is from the end of T wave to the end of QRS complex to the onset of T wave. It is the level relative to the isoelectric line, and shape of the ST segment is also very important. Depression of the ST segment is a feature of subendocardial ischemia or injury, but is also seen in patients with digitalis effect. And elevation is an hallmark of acute myocardial infarction, transmyocardial ischemia or injury, sometimes as a normal variant in patient with intraventricular conduction defects and in pericarditis. Now T wave, we have to see the direction, shape and the height of the T wave. Normally T wave is upright in lead 1, 2 and leads V3 to V6, and normally is inverted in lead AVR. It is variable in lead 3, AVL, AVF, V1 and V2. Normal T wave is rounded and asymmetrical and becomes sharply pointed in hyperacute myocardial infarction, and it is sometimes notched in patients with pericarditis or sometimes normally in children. Normal T wave height is less than 5 millimeters in limb leads and less than 10 millimeters in precordial leads. Tall T waves are seen in patients with myocardial infarction, ischemia or in patients with hyperkalemia. Now QT interval is a very important interval, which is the interval from the onset of QRS to the end of T waves, and it defines the duration of ventricular systole. It varies with heart rate, and so a correction has been applied. The corrected QT interval equals the QT interval divided by the square root of RR interval. Prolonged QT intervals implies a corrected QT interval more than 430 milliseconds and can be either idiopathic or because of certain causes like ischemic heart disease, rheumatic myocarditis, hypokalemia, hypocalcemia, hypothermia or certain drugs like quinidine, procainamide, amiodarone and phenothiazines. Prolonged QT interval indicates prolonged repolarization of the myocardium and predisposes to reentrant arrhythmias and may lead to polymorphic ventricular tachycardia, syncope or sudden cardiac death. So the recognition of prolonged QT interval is very important. Here you see the QT interval from onset of Q wave to the end of T wave is about 3/4 of the total RR interval. So this is markedly prolonged QT interval. Here again in this ECG you see that the QT interval is very long. A simple rule is, if you measure the QT interval in millimeters and see the RR interval in millimeters, if the QT interval is more than half of the RR interval, it is prolonged. So this is a simple way in which one can calculate the QT interval. Here is another patient in which you see that the QT interval is very short. it is another entity, short QT syndrome, which has been recently a focus of attention, again as a cause of sudden cardiac death, but it is very, very rare. The short QT interval can also be caused by hyperkalemia, hypercalcemia due to digitalis, or sometimes idiopathic as a cause of sudden cardiac death. Now U wave are low voltage deflections and have the same polarity as the T wave. They are best seen in V3 and become very prominent in hypokalemia. Reverse polarity of U wave may be seen in ischemia and patient with LV overload.
Thank you, Dr. Bhargava. You have very nicely explained the basics concept in ECG. I would like to ask you, because sometime our DNB candidates, they may be working in the wards and they may be required to perform ECG on a patient. Technician sometimes is not available. So quickly, can you tell us what are the key points they should keep in mind when they are doing the ECG on a patient? And nowadays, again, the computerized reports of ECG is coming. So what is the value of that report? Will you quickly?
Yeah, I will answer the second question first. The computerized ECG, most of the time they record the measurements and intervals very correctly, but their interpretation may not be always correct. So you always have to look at the basic ECG deflections and the intervals yourself on the ECG, and should not go only alone on the basis of the computerized ECG report. But sometimes they may help the paramedical staff in reaching a diagnosis, because they may not be knowing how to interpret the ECG. Now recording of the ECG is usually a job of a technician, but many a times in rural settings you may not have a technician available all the time, and sometimes you have to record the ECG yourself. So very important points you should remember is that you should place the leads correctly, as I have already explained. Number 2 is you should check that there is proper earthing. Then the electrode should be placed on the chest with proper conducting media, like a jelly should be used in abundance, and if the chest electrodes should preferably be placed after shaving the hairs from the chest, then only you will get a very good recording of the ECG. And these are the precautions. If you take these precautions, a good ECG will always be recorded.
Is the interpretation of ECG is different in children and adults?
Yeah, that's a very good question. The whatever I have told is basically applies to adults mainly, and the interpretation of ECG may be different in children. Even the heart rate itself is higher in children, so the pediatric ECG interpretation requires more skills and more knowledge of the ECGs.
So I hope our DNB candidates have benefited out of this discussion. We will continue with the ECG in our next session, which is going to start at 2:30, and it will be another 45-minute session. And in this next session, which is coming up at 2:30, please ask question. We have displayed our fax number, phone number. There is a toll-free number. Please do ask questions. And in the next session, we are going to cover how to interpret different types of arrhythmias. Then, of course, some important hints will be given to the examination students for their examination, like what type of ECGs can be put in the examination. And again, I expect from the students more active participation. We have some students in the studio also. I hope in the second session they will be asking questions. So I once again thank you all, and be available for the next session, which starts from 2:30 p.m. And let me remind you, we have another 2 sessions which will be covering the endocrinal spotters and interpretation of data. So thank you very much, and be available for the next session.